Everyone, welcome back. My name is Scott Glacier. I'm one of the ultrasound fellows here at Massachusetts General Hospital, here with a couple cases today. Before I go into the cases, quickly want to go over what to look for in both a cardiac and lung ultrasound. When we do an echo looking at the heart, you want to ask yourself a couple questions. One, is there fluid, a pericardial effusion? You look at that to make sure that there's no fluid anterior to the descending aorta. Sometimes you can see a pleural effusion when it goes posteriorly. You also look at the ejection fraction. You can focus on that with the mitral valve and see, does the leaflet hit the wall. In addition to that, you look at the parasternal short to see, is it contracting together well. Then you also want to look at the left ventricle compared to the right. Is there any sign of right ventricular strain that would be concerned with right-sided pressures? With lung ultrasound, you want to focus on the pleura and also looking at the spine, kind of in the fast view. You want to look for, is there B lines that indicate there'd be fluid inside the lungs, interstitial edema, or you also want to look for, is there a pleural effusion? We also look for subpleural consolidations that could be findings of an infarct in someone with a PE or pneumonia in those who have a fever or a cough. With this view here, again, I want you to focus on that you see the spine here and then the diaphragm comes up in this direction. If the spine were to continue kind of in a train track form, that would be a positive spine sign. But here, you don't see the spine continue. It kind of gets stopped in this aerated lung and then the diaphragm continues, and this is a negative spine sign. So the first case, this occurred when I was doing educational scans with some of the PAs here at MGH. Both cases, the history is pretty vague on purpose. They had complex medical history. They were short of breath. And you really, by EKG and by vital signs, by history, by the physical exam, by testing, you're not really sure what the diagnosis is. And so we were asked to do an ultrasound. This is a echo here. This is a parasternal lawn, though very oblique. You can tell here that the ejection fraction is pretty good. In fact, you could argue that the heart is a little hyperdynamic. The mitral valve is almost hitting the septum. You have your descending aorta, and you don't see any fluid behind it. This is your parasternal short. Again, you have your descending aorta here that indicates there is no pericardial effusion. Again, though the image is oblique, you still see that the left ventricle is contracting pretty well and coming together nicely. No clear wall motion abnormality. And then finally, this is more of a apical 5-chamber. The LV compared to the RV, there doesn't seem to be any RV strain. You could argue that because you don't see the right atrium too well, that this is not a good enough image and you need to optimize a little bit, but for the sake of this case, we called that there was no RV strain. When we did lung ultrasound, though, we found a very impressive positive finding, which was this, a very large pleural effusion. If you remember that the first image I show you, you should see the spine disappear and you have the diaphragm curve up like so. However, you see the spine continue because now there's all this fluid that would be a nice window for sound waves to travel. In addition, you notice here that the diaphragm is curving up, but here because of the pressure, it's now curving down. This was seen on x-ray eventually, but we had the diagnosis before the x-ray results returned, which made the disposition faster. So patient was admitted and eventually got thoracentesis. The second case was almost similar. I just copied and pasted the first slide because they both had complex medical history. Again, they were in their 80s. Vitals were unremarkable, and EKG exam couldn't really tell you what was going on. Labs weren't as helpful yet either, and so we were asked to do an ultrasound, and here's what we saw. This is your first image. This is an echo as well. You can focus on a couple things. This is the descending aorta. There doesn't seem to be any fluid around the heart, but first thing you notice is a very large LA with a mitral valve here and a thick septum. A better image comes up here is that the ejection fraction is preserved. You see the walls pretty much touching each other, but there's not much fluid getting from the left atrium to the left ventricle because of the thickness here. There's also some calcification of the valve. Here's the aortic outflow tract, and here's the right ventricle. When you do a parasternal short, you can see this is the tiny, tiny amount of blood that's in the left ventricle, and then you have this large right ventricle here, comparing the two, that is concerning for RV strain. We tried to get a good apical 4-chamber, which was a little bit more challenging, but based on the two images that we saw before, there is RV dilation. Now, we want to caution you, not every single RV dilation is in the setting of a PE. It could be in a patient who has CHF, and now there's a lot of right-sided pressures can cause that. Interstitial lung disease, anything where the RV has to pump against a high-pressure system, it's going to eventually dilate. Another thing you can tell too from this image and the other image is that the free wall is moving pretty well, so to me that indicates more of a chronic problem. But I did want you to focus on the fact here that you not only have a large RV, but that you have a very large left atrium that is concerning for diastolic failure. When we skip ahead to the slides, we then did a lung ultrasound, and this is zone 1, this is zone 5. I apologize, we didn't delete the 1, and you see B lines at both spots, and these are at the apex, and so if you see B lines here, this is concerning for interstitial edema. So when you have this image here plus these two, you are concerned about heart failure compared to what we discussed before, a normal beating ventricle and a normal sized left atrium and A lines. When you then have a ventricle with a that you can barely fill, a dilated LA, and B lines bilaterally in the apices, it is concerning and pretty I would say would make me think of CHF and would be hard for me not to treat it as such. Turns out that the team eventually felt the same way, and the patient was admitted, got Lasix, and felt better. So the point of these two cases were to show that how you can do an ultrasound of both the heart and lungs in patients who are short of breath. You can also do this in chest pain. And it often will give you a lot of information that really help in diagnosing what's going on. It will limit unnecessary tests and really point you in the right direction, because there are a lot of 80-year-olds we see who are short of breath, and it could be anything from a PE to pneumonia. So in addition to a good history, a bedside ultrasound with both the heart and lungs can really put you in the right direction. Hope these cases were helpful. Thank you to the PAs who ultrasounded with me and submitted these cases. Any questions or any comments, please email us, mghedus@gmail.com, mghedultrasound@gmail.com. Thanks.